Welcome to the Complex PCI Workshop 2, Calcification. I'm H.S. Kim from SNU Hospital. My co-moderator is Dr. Sunao Nakamura from Japan. We have eminent panelists, Dr. Amir, Aziz, Alkatiri, Dr. Yeonjun Hong, Dr. Sehun Kang, Dr. Zhen-Yu Liao, Dr. Choutchung, Tinakorn, Ayudhya. It's very difficult. Anthony Yu, Tung, Wong. We have two cases. The first case is actually from Dr. Wu from Taiwan, but he could not arrive because of cancelled flight. Thus, instead of him, Dr. Jung-Min would present the master's case 1. Dr. An, please.
Thank you, Chairman. I am Jung-Min, but Dr. Wu is not here, so I replaced his role. Actually, I'm not the master, but the coronary calcified nodule simple IVL versus Rota-tripsy. Rota-tripsy, I think, rotabulation and Rota-tripsy combination. This is Dr. Wu's case. So 85-year-old female, history of type 2 diabetes, hypertension, hyperlipidemia, and CKD creatinine is 4.0. Intermittent chest tightness and dyspnea on exertion, relieved by rest. Echo show that the preserved ejection fraction. Thallium SPECT show that the apical anterior inferior lateral reverse filling defect. Actually, this is an angiogram, diffuse LAD disease, and circumflex as well, and RCA disease. So I think this is the case for patient, the Anthony.
Okay, so thank you so much, Dr. An. So I'm Dr. Anthony Wong from Hong Kong. So very honored to be here. And so if I was doing the case, how would I do this? So basically, in summary, this is a very old elderly lady with history of kidney failure with eGFR of only 10. She was symptomatic with active ischemia documented on thallium scan. And coronary angiogram, as we know, it shows severe triple vessel disease. And actually, the STS score is high, around 10, 11, and the syntax score around 30 something. So basically, high syntax score, high STS score. So first, actually, how should we treat her? I think CABG is always something that we should consider, although in this case, the patient's profile actually speaks against the use of CABG. I think no surgeon would dare to do open heart surgery for this very old lady. And then for PCI, of course, this is the topic today here. We do complex PCI. But frankly speaking, I think optimal medical therapy is one good way to treat this patient. As we all know that medical therapy in a patient with stable angina is actually not bad, maybe even superior than proceeding to a complex PCI. Especially the patient is actually not presenting with acute coronary syndrome. So I think optimal medical therapy would be an option. But anyhow, let's proceed to the PCI. So if we do PCI for this lady, which side first? Let's look at the angio again. So this is the left side. You can see subtotal occlusion over the LAD, or actually maybe a CTO. For circumflex and ramus, there's diffuse mid to distal disease. For RCA, you can see a heavily calcified proximal RCA with an eccentric chunk of calcium along the outline of the vessel. So which side would you treat first? For me, I think because if I treat the RCA first, there may be something happen to the RCA, and then the LAD flow is already not good. Then the patient may go into cardiac arrest at the same time immediately. So for me, maybe I will do PCI, or add 10 PCI to the LAD first, trying to open up this subtotal occlusion. If it is successful, then I will then proceed to RCA. For circumflex and ramus, I wouldn't touch. So to facilitate this complex PCI, of course, we need imaging, right? Angiogram alone should be out. We need IVUS or OCT. For me, patients with nearly end-stage renal failure, I will choose IVUS to save contrast. Of course, OCT with dextran use is another option. But for LAD, I don't think we can put the OCT down there. So maybe, even IVUS, I don't think we can put IVUS easily across that LAD occlusion. But anyhow, for me, the first choice would be IVUS, although I know that for calcified lesion, OCT may yield more. So we need to modify plaque, obviously in this case. Would you use just high-pressure NC balloon, scoring balloon, or cutting balloon? Or would you choose rotational atherectomy, orbital atherectomy, or intravascular lithotripsy? So for me, the LAD actually is subtotal occlusion, so no doubt, just upfront rotablation, because other things shouldn't pass. For RCA, maybe orbital atherectomy is a good choice. It actually depends on imaging. If on imaging you found that there's calcium nodules, then you need some kind of plaque volume reduction, then you can choose orbital atherectomy or rotational atherectomy. This is rotablation. And if we use rotablation, you can see that actually the outline of the calcium lies on the lesser curve of this proximal RCA. For me, I may choose an extra support rotor wire to facilitate the wire bias towards the calcium part so that the rotablation will be more effective. If on the imaging, I can only see circumferential calcium but not calcified nodules, then I may use intravascular lithotripsy, which should be effective and safe in this case. So it really all depends on imaging. So in summary, how would I treat this patient? First, I would definitely discuss again with the family whether they really want to proceed with PCI, which is actually a very high-risk procedure, so medical treatment should be considered. And if we come up to a conclusion that we need to do PCI, always imaging guidance. I'll treat the LAD first with upfront rotablation. For RCA, it depends on imaging, whether you can see calcified nodules, circumferential calcium, or whether the calcium is superficial or deep. And if I choose rotablation, I will choose rotablation with extra support guide wire, and then followed by NC balloon angioplasty at high pressure or intravascular lithotripsy. It depends on how the imaging look after rotablation. And most importantly, use the least amount of contrast. Basically, I would prefer ultra-low contrast volume use that is defined to be contrast volume just less than the EGFR. So maybe 10 or 15 cc for this case. It would be very, very difficult. So basically, just the angiogram as a roadmap and the final angiogram as the final result. In between, all relies on imaging guidance. So imaging guidance is the utmost important in this case. So thank you. I will give the stage back to Dr. An.
Great, thanks for your really wonderful, smart approach. Dr. An, please.
So thank you, Anthony. I think Anthony answered most the solution. So, but Dr. Wu, I think Dr. Wu thought a little bit different, because Dr. Wu didn't give me any LAD intervention angiogram. So I think that he wanted to treat this patient LAD medical treatment. He focused on the RCA. So after angiogram, very calcified RCA, proximal RCA, he performed the OCT. So very calcified, protruding calcified nodule. They're using not the contrast, but he used the 10% dextran. So he made a very nice imaging, even though dextran used. You can see the very thick calcified surrounding the more than the 180 degrees, very thick calcification. So he decided to do the rotablation first. So actually, I didn't know this maneuver. So initially, he used the 1.5 millimeter rotabor. Initial speed is 180,000 RPM, gradually decrease rotor speed from 170, 160, 150, finally 140, and then advancing and gently packing. Final speed is 140,000 RPM finally. So after rotablation, so I'm sorry, this is a contrast test. And then after he evaluated OCT again, OCT imaging is very beautiful. Look at here. Rotablation made a big hole. I was very surprised to see this imaging, very beautiful and very informative imaging. If we use the rotablation using the decreased bore speed, it can make a big atherectomy space. And thereafter, he decided to do IVL, 4.0 12 millimeter balloon and 80 pulses from 4 atmosphere. So he combined the atherectomy, rotablation, and lithotripsy. So he made his title, Rota-tripsy. So after rotational atherectomy, this is after IVL, more breakage of the calcification, bigger lumen, and then he implanted a 3.5 48 millimeters and post-deal using high pressure balloon. And this is a final OCT. Relatively well opposed, well expanded. Lumen is big. So the stent covered all lesions. So after rotablation and IVL, then stent implantation, final angiogram, it looks very nice. So, and then he also showed that another case, this is the eruptive calcified nodule. This is eruptive calcified nodule OCT imaging. This is eruptive calcified nodule. And he decided to the IVL. Some breakage of calcium nodule. And he implanted a stent after high pressure balloon. Also, final result looks very nice, very expanded. The stent looks like a little bit eccentric, but the lumen size is enough big. Final angio looks fine. And this is his take-home message for calcified nodules. Challenges arise with a thick, eccentric calcified plaques in PCI, often leading to stent underexpansion. So in patient with kidney disease, 10% dextran instead of contrast can provide a satisfactory OCT imaging. Yes, he made a very beautiful OCT imaging using the dextran instead of contrast. Imaging guided a relatively large bore rotablation with utilizing wire bias, decrease the speed, then gradually decreasing the rotor speed, create an horizontal deburking effect. This method helps in avoiding potential barotrauma or extensive dissection by a high pressure NC POVA. Imaging guided Rota-tripsy rotablation and lithotripsy treatment transformed the eccentric calcium to concentric through rota deburking and soften the residual calcium by microfracture of IVL, ensuring optimal stent expansion to improve the long-term outcomes. Simple IVL for calcified nodule, possible need more pulses. OCT may under detection of calcium fracture with the micro CT or histology. Thank you for your attention.
Yeah, a wonderful case. That is open for discussion. Is there any comment from the panels?
So actually, I think no discussion. Actually, the Rota-tripsy is a much better treatment for that in this kind of cultural lesion. But actually, this is a bit the sad story in Japan. Actually, the Rota-tripsy is not, strongly prohibited by the Japanese FDA, so we cannot do. But the Rota-tripsy is the best treatment.
It's very expensive. That's the reason why the government restrict the usage of both rotablator plus lithotripsy. My personal point is, even though he did not use IVL after rotablation, the ablation was very effective. Thus, we can get the same results. Then we can save IVL, very expensive IVL. Thus, I'd like to raise an open question. Which is indication of both rotablation and IVL instead of rotablation alone?
Maybe I think this is a little bit difficult to explain, but depend on the location of the calcification and the size and the thickness of calcification, also the wire bias. So in this kind of, so if the number one case today is a pretty much a good indication of the Rota, and cut some very nice part of the calcification, and then the using a Shockwave. This is pretty much good combination. Use Shockwave, but actually the little bit difficult to predict the running path of the Rota or with the guide wires.
Yeah, I agree. Even after rotablation, there is still concentric calcification that does not have crack. Then we may need kind of appropriate size, big balloon IVL to make a crack of the concentric, a little bit big lumen that is not reached by a rotablator. In that case, I think the IVL would be helpful. Yeah. Dr. Lee?
Hi. So I may be one of the few minority, but I do not believe that there's a role for combination of atherectomy and IVL. Number one, it's cost prohibitive. Number two, there's no data. We had a 2-hospital registry, our hospital and St. Francis. We had 458 patients, and our procedure success rate was over 98%. To your point, if you don't have enough debulking or you don't atherectomize enough with rotational atherectomy, you just go to a bigger burr. Or with orbital atherectomy, you go from low speed to high speed. I think with adequate passes, you do achieve sufficient adequate plaque modification to successfully complete the case. So again, I do not feel that the Rota-tripsy, although it's a nice, fancy technique, that there's a role for that.
Because you choose usually either one.
Either one.
Rotablate or IVL.
Because your goal is plaque modification. You will eventually achieve plaque modification with rotational atherectomy if you step up and escalate your size of your burr. If you don't achieve adequate plaque modification with 1.5, go to 175. If you don't achieve adequate modification with 75, go to 2.0, and 99% of the time you're going to be just fine.
Okay. Anyway, in this case, we have a lot of information when you use rotablation. The first one is when you see eccentric plaque, usually located in less coverage because of low shear stress and predisposing to the atherosclerosis, and that site may be debulked with extra support wire. We expect wire bias. Then burr preferentially pass such kind of less coverage. The second point he used is reduction of RPM from 180 down to 140. At that time point, we can expect a little bit orbital motion of burr. Thus, we can make a bigger debulking area that is well demonstrated in OCT. In this case, CKD, thus we do not use contrast dye-based OCT, but he taught us dextran 40 would be less nephrotoxic than we can do OCT even in CKD patients. I think it is very informative, educational case.
Can I make a comment? Okay. I think Dr. Wu want to introduce the in lithotripsy after Rota because he believes the lithotripsy can give rise to some microfracture of the calcium which cannot be seen on imaging. So I think this is what he believes, and that's why that could improve the elasticity of the vessel when you stent the vessel. But anyhow, it is a very expensive strategy. And for me, actually, I think after the rotablation, you see a very beautiful debulking result. Maybe we can try an NC balloon first and see how it goes. If the NC balloon expands well, then why not just go for stenting?
Okay, to time limit, we have to move on to the second case, Master's case 2. That should be
Lecture.
on lecture.
Yeah.
Okay, lecture.
Vincent.
A shockwave IVL, the good, the bad, and the ugly. Dr. Kwok, please.
Good afternoon, Mr. Chairman, expert panel members, ladies and gentlemen. It's my privilege to share with you our experience with IVL. I was told that Korea will have the IVL system very soon. Are you using it right now?
No.
Not yet. So it's my privilege to share with you our experience since 2019. And as the previous case illustrated, that intravascular imaging is indispensable in lesion preparation. And calcified nodule is the most stubborn calcium, and the eruptive calcified nodule is the accumulation of small calcium fragments with underlying calcified plaque. And nodular calcium is actually healed cardiac calcific nodule with a fibrous cap. And all these are very difficult to treat, and you need many pulses if you use IVL to crack or fracture the calcium. Just illustrated in the previous case, I think Dr. Wu used up all 80 pulses in cracking the calcified nodule. And even in post-atherectomy studies, we find that these calcified nodules are very stubborn and they could protrude through the stent struts. Concentric calcium is the most perfect case for IVL starters. And we have a lot of calcium scores that we can use, but in the real world, I think we use our judgment instead of calculating the calcium score. And we all know that if we have 360 degrees of calcium, we need some form of plaque modification. And these are algorithms for beginners, and we all know the basic principle: uncrossable, undilatable lesion, we need atherectomy up front. And you see nodular calcium, of course, you would think about IVL or atherectomy. I will also add the narrow, if your NC balloon or your high pressure balloon or cutting balloon fail, you can try IVL. And it's very user-friendly. I will show you cases. And we know that there are a lot of contenders in the pipeline now, not just the Shockwave IVL. We have the contact stress IVL, which is on the pipeline, which has preliminary promising results. We have laser-based IVL. We have non-balloon-based Shockwave IVL now available for peripheral use. And I was told that the Shockwave IVL will have some modification to tackle calcified nodule with more precise and more pulses and energy across the calcified nodule. It's a more focused energy. And you know the principle of IVL giving out short bursts of sonic wave. And mind you that the pressure that generates is not the 4 atmospheres you inflate on the balloon. It's 50 atmospheres. So it still can cause a barrel trauma. And it has been studied robustly in the Disrupt-CAD trial, and it worked across all the spectrum of calcified lesions, concentric, eccentric, and nodular calcium, and there was no difference between calcified nodules versus non-calcified nodules in terms of outcome. Ventricular capture is very common, and we have reported it in JACC in 2019. in the very early days. It echoed with our European colleagues. And I think most operators will overlook this. This is a very calcified LAD critical stenosis, and you can see the napkin ring with the cutting balloon at 12 hemispheres. It hardly did anything to the circumferential deep calcification. With the Shockwave, you crack the calcium nicely. And you can see the ventricular capture during the IVL. So no big deal, right? But it happens in over 70% of cases. It's a mechanical electrical coupling. It's more common in bradycardia patients. It has a potential risk of ventricular arrhythmia and pacemaker interference. And this is a case report with a VF induced by lithotripsy pulse on T during the IVL. So there is a potential risk. And I hope that they would have ECG gating in the future. Rota-tripsy, Rota-Chalk is a very attractive option and very fancy option for uncrossable, undilatable calcified lesions, especially in deep calcification. And this is the complex LAD case where the wiring is already very difficult. And once the operator crossed the wire, nothing got through. Of course, the smallest balloon with the guiding extension couldn't get crossed, and he lost his wire position. But mind you that if you can cross with this struggle, don't push. If you push it through the lesion, it ruptures, and you can't get the balloon out, and the balloon may get stuck. So once we exchange for rotor wire and do a rotablader, even with a 125 burr, we can complete the job with a 2.5 Shockwave balloon with a very nice angiographic and intravascular ultrasound result with a very good stand extension. Another case with a planned rota-tripsy where you can appreciate the calcification, very long, very calcified tortuous LAD, and also the left circumflex lesion. And again, this one we'll use a rotablader up front. You could appreciate the circumferential calcification even after rotablader. So we open the Shockwave balloon and fracture all the calcium with a nice dissection and fracturing of the calcium. And this is the final angiogram showing very symmetrical expansion of the stent. And we complete the job with the circumflex Shockwave and stent, and you could appreciate the calcium on the intravascular ultrasound as well. Very nice result. Do not stent if the lesion is not well prepared. This is the principle number one. This is a very diffuse, long segment RCA, huge RCA calcified lesion. And the operator actually used the guiding extension to deliver a high pressure balloon and implanted a very long stents across the RCA. He thought the job was done, and he thought that he could achieve the stent expansion with high pressure balloon inflation, but you could appreciate the napkin ring again. And this is very under-expanded stent. All right, so we use the Shockwave to expand the under-expanded stent and achieve a very nice result. And actually, this has been studied in the Crunch registry, where you use a IVL in treatment under expanded stent. In this study, 40% of the stents were freshly implanted stents. All right, some were, of course, ISR, and it can achieve about 20% further stent expansion. Of course, it will not fracture the stent, but it will fracture the polymer, and we don't know the future or the result or outcome of these patients. Left-main IVL is safe, I should say. We have a patient with elderly patient, calcium score over 3,000, heavily calcified left-main and LAD, RCA. We shock the RCA and implant the stents. I should say it's a very user-friendly device, and the procedure would be faster by instead of upsizing the rotablader if you use a rota-tripsy. And you could appreciate the calcium along the LAD and left main. All right, we shock the left main with two different sizes. We implant the stent. You can see very nice expansion of the stent, very symmetrical expansion of the stent after the IVL. For time constraint, we'll not go through all these cases. There's another left main bifurcation, an LAD diagonal bifurcation lesion, and heavily calcified left main LAD, and critical diagonal stenosis. In this case, we applied Shockwave plus culotte stenting across the left main and the diagonal to achieve very nice result. But sometimes it's not without risk. And you can have Shockwave triggered tsunami, especially when you are performing the IVL, the balloon rupture. And you could unzip the whole vessel. This is a LED calcified lesions, and the balloon actually ruptured during the first cycle of the IVL. You can see that there is a spiral dissection all the way down the LED, distal LED, and the patient got chest pain and ST elevation. So it's not the 4 atmosphere, it's the 50 atmosphere equivalent barrel trauma. And we have to, of course, stand the whole thing and rescue the patient with the full metal jacket because this is an unzip of the vessel. And achieve very nice result. We proceed to the RCA in the same sitting. So the take-home message is the good thing is it's a very user-friendly device. Unlike atherectomy, you don't need a very steep learning curve. Good for concentric, eccentric, and calcified nodules. Of course, you need more pulses. And standard, and it can be applied in stand and expansion, especially in bailout cases or old stands which were not well expanded, safe and effective left main. Rota-tripsy is very attractive, but we need more data. The bad thing is expensive, but we have more China-made or other competitors which will lower the cost of the procedure. Unknown long-term sequelae, would there be any deep barrel trauma? The profile is similar to the OBN or cutting balloon, and you may need the 2.0 NC balloon to predilate. The ugly is that the balloon burst during IVL can be detrimental, and coronary perforation has been reported, and shock topic is common, and you just need to pay attention, but you don't need to, prepare for defibrillator for every case. Thank you very much for your attention.
Dr. Kwok, can I ask you a simple question? How do you determine the number of pulse in your daily practice? Because we don't know the complete breakage of calcium before we use OCT IVUS or test ballooning.
It's a difficult question because once if you remove the balloon from the lesion and did an imaging again, and you may not be used the same balloon to cross again because it's very winged. So it depends on the shockwave assessment. If it is a very heavily calcified, if it's a calcified nodule, I think you have to prepare to use more pulses upfront instead of just use image guidance intermittently because it would be very costly procedure.
How many is the upper limit of pulse number? 80?
For the current C2 catheter is 8 cycles, and each cycle is 10 seconds, 10 pulses. So 80 cycles in total. But we are now using some China-made shockwave. They can deliver more pulses per catheter.
Do you use a higher pulse number when you break the calcium in the underexpanded stent segment because of interference of stent?
In the underexpanded segment, it may be easier because you can do stent boost and you can tell whether the stent is expanded with your system. Then you may apply 2 more cycles to make sure that it's well expanded.
So you need more pulse.
I would play safe and
because of the
more,
interfering metal stent.
Yeah, 2 more cycles,
okay.
Meaning 20 more pulses.
Thank you very much.
Thank you.
Let's move on the second master's case to Dr. Ishihara could not arrive here because of flight canceled. Instead of him, Dr. Nakamura will present the second case, strategy of rotational atherectomy for severe calcified lesion at the left main bifurcation.
Okay. Just 1 hour ago, he just called me to refresh him. Anyway, we have bad news and good news. Bad news is he cannot make it because of big swelling. Good news is he's coming on the plane. Maybe he can come until the faculty dinner. Okay. Anyway, just he want to say the calcium nodule is the biggest problem, the biggest enemy for us. The cases like that, congestive heart failure, maybe acute or chronic heart failure, the angina because of the RCCT on the left main, very severe calcium lesion. This is the chest X-ray and some CT, ST depression of the ECG. And good news is good renal function, ejection fraction is moderate. This is the case. Very ugly face of the left main, just severely calcified. And also RCCTO. Maybe can stop here. And maybe I think the next.
Okay, good. It's very tough lesion. Then Dr. Alkatiri will present how would I treat the case. Dr. Alkatiri, please.
Thank you very much, Mr. Chairman. Actually, Dr. Doni also cannot come here, but I'm sorry I don't have a picture of him, like, because of flight cancellation due to weather, so I will replace him. So what we deal with this very nasty calcification here, you can really appreciate the nodules here, especially at the ostial of the circ, and also the mid part of the circ, and also the distal part, or even probably is ostial part of the LAD. So very huge calcium nodule. And also, we have also the right side of CTO. I think very difficult situation here. But if we see the syntax score in this patient is 34, we see the guideline, of course, this is on the high side, and then the bypass is one of the choice. So the master plan is, of course, we don't hesitate to send the patient to surgeon. That's something that's why we have a shared decision making, right, in the coronary conference. But of course, we are interventional cardiologists here. We are not surgeon. So we have to think of patient preference, the frailty, the comorbidity of this patient. So there must be something worth to do as interventional cardiologists. So which one to open first? I think looking at the lesion, especially the RCA CTO, of course, due to the safety issue, of course, we need to go for the CTO first, and staging to the left main to the circ in the other time. And intracoronary imaging is mandatory. So how to tame the calcification? So calcium nodule, of course, the challenge is atherectomy. We don't really have a firm data regarding which atherectomy to use, whether it's rotational atherectomy or orbital atherectomy, also the issue of wire bias and minimal debulking, and also the dedicated balloon of intravascular lithotripsy, of course, one of the choice, like Rota-tripsy, like the previous case. But of course, many countries doesn't have a lithotripsy also, like Indonesia also we don't have. Sometimes we have a strategy of rota-cut or rotational atherectomy plus cutting balloon or a scoring balloon. So I think very important also for calcium nodule to really reduce, really do the bulking, not only fracturing, but also to reduce the volume. So with a rotational atherectomy. And also do the lithotripsy. So I think this is some strategy to manage complication. Of course, if we see again the lesion, the issue is not whether the intravascular imaging can cross, but even the basic thing, whether your wire can cross the circ. That is, I think, very basic. Even if you manage to cross the wire, I think very difficult to advance your intravascular imaging catheter. But there is a data from Sakakura, I think, mentioning that even if you cannot cross your intravascular imaging, you can still use 1.25 or even 1.5 with comparable complication regarding 1.25 and 1.5. So I think very important to see also the prevent and to manage the complication. And starting with a small burr, I think very 1.25 is one of the choice. Thank you very much. Very calcified.
The answer is actually he has another problem with the access side. But we are professional, we can manage. Anyway, we need to focus on which region first, RCA or left main or some kind of risk management. Anyway, still, now we have a lot of the CT operator in all over the world, but still, so in Japan, CTO country, easy, it's okay, fast. And the point is left main calcium. This is big size, the huge calcium in the left main bifurcation area. And he really want to say that this is kind of the stage Rota procedure. If we use that kind of way or the Rota to circumference, we have some risk. So he just really want to say stage procedure. Left main to LAD first, and then cut, and then avoid the bar stack, and avoid the perforation, and then go to the circumference. This is really he want to say. First, Rota left main to LAD 2.0 bar, and then using a crusade to wire pass, and then the left main to circumference. And then he used the DCB. Of course, we don't have solid evidence for the efficacy of the DCB in a calcified region, but if you look at the final result, maybe I think this is acceptable. So the point is, anyway, just he really want to say, anyway, I have one case like this. If we have like more than 19 degrees the wire direction, maybe sometimes we cut the wire itself by the Rota. So this is a very high risk. So this is really he want to say. Actually, he called me from the morning, just like a 30 minutes talk. He really want to emphasize this. This is the stage procedure. Not going to the circumference, not going to the LAD and the cut some part, and then do this. I think this is a very reasonable and a very good treatment way. Thank you very much for attention.
Okay, this case open for discussion. Is there a comment from the panels? The final results, he did not implant stent.
Yes. So actually, like in a pre-discussion, so why use IVL? Why is like a high pressure? Because we want to get a very good stent position, so use IVL. So in this kind of case, just using a Rota and even a high pressure, maybe we still have a lot of the big size of the calcified lesion around there. So he really afraid of the not good stent position. So avoid the stent implantation and just using a DCB. Maybe I think.
This is really an extreme case that opposed to the previous session. One stent or two stent, that's just, he did not even implant stent, just Rota ablation, and circ-os is treated with just DEB angioplasty, but wonderful results. So we have to acknowledge such kind of extreme case may be possible. We have to expand our imagination. Okay.
Yeah,
okay.
Yeah, I have one question, and I think Dr. Shoujo is trying to showing some very acute angle, very severe subosteum is calcified region, looks like a very tight, and he tried to Rota first from the LAD to the left main and then try to wire. So I think many audience is questionable, is wondering how can you guarantee, is it, you know, and if you're gonna do rotablation from the proximal LAD left main, there was a total risk of total obstruction of the subosteum. We cannot never cross the wire. So how can guarantee, in the, Dr. Sunao, you have experience about some acute angle, very severe calcium subosteum, and I'm still some hesitation is from the LAD rotablation. There was a total risk of total obstruction of the subosteum. Could you comment on that?
I think you're okay. God love you very much. I think technically and theoretically, this is a rock kind of, calcium is a kind of rock. It's a natural kind of a natural stent. Maybe if you can cut some part, maybe kind of the shift is never happen. And just I think.
I think it is totally different from ballooning. When we expand the balloon, there is a total change of morphology around the bifurcation lesion and the shift of plaque. But rotablation, burst size is not so big, just cut. It's very clear cut only. There's no change of morphology. Thus, I also agree. There is a stability of side branch osteum, even though we perform rotablation main vessel.
Maybe I think also that you need to consider the wire angle. If the wire angle is a very much high angle, maybe the risk of the cut the wire by the rotor itself. So this is very dangerous.
Did he use extra support rota wire in circ? You don't know.
I never experienced.
I think that if we use the same devices, but the first case and the second case is a little bit different is our treatment goal. But the first case is very thick in circling calcification. So if we use the rotablation, in this case, we wanted to make a crack. But in the second case, with the calcium nodule, we don't need to crack those calcium nodules. We want to reduce the amount of calcium nodules. So actually, if we do the imaging and those calcified lesions, we make the clarify our target, making the cracking along the calcium lesion or the reduced amount of the calcium nodule. And if we also use the same rotablation, make the different goal, and the different goal will ensure the simple and clear-cut PCI. So before the rotablation, we do the imaging and make our clear goal is another important point.
Dr. Lee, I have a question for you in this issue. If you see calcified nodule, do you prefer rotablator or IVL?
I would not use rotablator. I would choose either from IVL or orbital atherectomy, because orbital atherectomy, you're more likely to get circumferential contact. Think about this, with rotational atherectomy, most likely it'll go down the path of least resistance. So I don't think it'll go down, because once it crosses, it's gonna not hit that nodule selectively, it will just go down the path of least resistance. Orbital, not only do you rotate, you actually have an elliptical path, you'll have 360-degree contact. And we also know that IVL, it works by really modifying and cracking at the shoulders, and that's where the main benefit is with those calcium nodules.
Okay. Other question, comment from the panels? Okay, it's time to proceed to the lecture by Dr. Michael Lee, Treatment of Severely Calcified Left Main Disease. Dr. Lee,
Great,
please.
thank you. You know, today is actually Thanksgiving in the United States, but I'd rather be here talking about complex PCI and left main, so it's really a pleasure to be here. I think one way to really look at how cases go is to look back retrospectively. You know, this past month we just had our elections, very contentious, and the Democrats lost. So now what you see on talk shows is what happened, what's the autopsy? So today we'll talk about a case where it went very bad, and we can look at how we can learn and improve for this. So this is an 80-year-old patient with diabetes, and you can see in the proximal LAD, it's calcified. And it looks very straightforward. It's not diffuse. It's relatively straightforward. It's pretty discrete. So my colleague, and we reviewed this case together, my colleague decided to do just plain old balloon angioplasty to pre-dilate the lesion. This is just a 2015 balloon. And what you see here, very importantly, is that the balloon did not yield. And so this operator decided to do multiple repetitive inflations. Still didn't yield, but because of the repetitive inflations, this led to slow flow, ischemia, and you can see if you look very carefully, there is actually some staining of contrast here. So at this point, the patient had a circling of kind of a death spiral, had CPR because of the cardiac arrest, required resuscitation, downtime was about 10 minutes, was able to essentially get hemodynamic stabilization after Impella, but the surge response has already been activated. You get release of leukotrienes, you get hypotensive, you get vasodilatory shock. Eventually, they were able to do this PCI with rotational atherectomy, which ideally, in retrospect, should have been the initial strategy, but it's too late. So the PCI angiographically was successful, but the patient went to the ICU, 40 days of just misery. You know, you get trach, you get a PEG, they're in a persistent vasodilatory state, and eventually the patient expired. 45 years ago, the father of angioplasty, Dr. Andreas Grenzig, was really a Nostradamus. He saw that calcium would be one of the main barriers to PCI, and to this day, as well as the end of time, calcium will always be the main limitation of a successful PCI. So what are the challenges? We all know this. It's going to be difficult to deliver a balloon. If we get it there, it's going to be difficult to dilate. If we do dilate, it's going to be difficult to shove a stent in, and when we get the stent there finally, it's going to be difficult to fully expand it. And with this, it'll lead to poor outcomes, increased MACE, stent thrombosis, restenosis, and ultimately death. So what's the rationale for using these expensive devices like IVL, rotational atherectomy, orbital atherectomy? Well, number one, you want to be able to successfully complete the procedure by delivering the stent. And also, once we deliver the stent, we want the stent to be fully expanded so you have decreased MACE. So you don't want restenosis, you don't want in-stent restenosis, and you don't want stent thrombosis, which is the deadly threat. So let's talk about a couple of cases. Let's first talk about rotational atherectomy. So this is an 86-year-old female. She was a horrible surgical candidate. She had very bad lung disease. She had low ejection fraction. This is actually the mother of an interventional cardiologist from Bakersfield. She was truly a vasculopath in that she had stents in the mesenteric arteries, stent in the renal artery, and look at here, it's a dominant left circumflex. You see a severe osteostenosis, osteal left main disease, and look at this LAD, this long diffuse disease with aneurysmal dilatations. Again, surgery was off the table. So at this point, we decided to proceed forward with PCI. Given the osteostenosis, we decided to go into preemptive treatment with a two-stent approach. But because of the severe calcification, we thought that it was very important to perform plaque modification. This is a case where we chose rotational atherectomy. Because of the severe stenosis of the osteal LAD, we started to use a 1-2-5, but that was not going to be our final rotational atherectomy burr. So we stepwise gradually went from 1-2-5, 1-5, 1-7-5 to achieve the adequate optimal debulking and plaque modification. After this, with balloon angioplasty and subsequently in stenting, we put a 3-5/28 EES in the prox LAD. Then at this point, we proceeded forward with a two-stent strategy with a crush. So we put a 3-5-15 EES in the osteal circ, crushed that, and we did a 4-0-18 in the osteal left main. Again, we went to our classic LAL cranial projection. Afterwards, we went with the pot procedure, and we flared the ostium where we have half the 4-0 balloon and really go high pressure to kind of trumpet the ostium. We did kissing, and here's your final angiographic result. And this patient actually lived another 5 years until she was 92, or 92, excuse me. So let's talk about orbital atherectomy. This is one of my go-to devices in that it has the theoretical advantage in that you don't have to swap burrs. So you go from low speed, and typically we use a low speed from 2.5 to, let's say, a 3.25. But anything above 3.5 or higher, we go to high speed. And in fact, what was predictors of procedural complications was high speed. But again, typically don't go to high speed unless you're at least at 325, probably 3.5. But look here, if you look at this panel up here, look at rotational atherectomy. Because of how it spins, it's going to really selectively address the greater curvature, but not really address the lesser curvature. Whereas with orbital atherectomy, you get 360-degree contact with a vessel. So this is my preferred device for performing atherectomy. We all know about the Orbit 2 trial. This was a seminal study. Well, it was a single-arm study in the United States. This is 3-year data in very complex calcified lesions, a very respectable 7.8 TLR rate. Now, those were very highly selected, relatively healthier patients. Now, let's look at real-world patients where they were actually excluded from the major clinical trials. So this is our study with combination of data from 2 New York hospitals, 458 patients. If you look at procedural complications, it's very low. Again, you have people like Rich Slopnitz who have probably over 2,000 cases of orbital atherectomy, perforation, dissection, no reflow, all less than 1%. These are achievable in experienced hands. And if you look at 30-day outcomes and 1-year outcomes, a MACE rate of 12%, largely driven by TLR in the sickest of patients. These are patients that were surgical rejects, patients in cardiogenic shock, single last remaining conduits. So let's look at how orbital atherectomy was applied to calcified left main and LAD disease. So UCLA has a very large lung transplant program, and in this patient who had left main disease and a trifurcation, obviously CABG is not an option because you'll never extubate this patient. You'll be vent dependent. So at this point, we decided to try to make this patient a candidate for lung transplant. We proceed forward with orbital atherectomy of the left main LAD because of this long diffuse disease. So we talked about it has 360 contact, very straightforward. You make a couple passes very slowly, 1 millimeter per second. You come back and address the left main because it's a larger vessel. You go to high speed, you'll get very good contact and debulking and atherectomy. So this is your final angiographic result. We try to keep things simple, and we talked about the strategy of a single stent versus 2 stent. We stented across, and you can see there's some plaque here. We did FFR, it was non-ischemic. So you all know this last month, they presented the Eclipse trial at TCT. We were actually at a site where we enrolled patients. To our surprise, in fact, there was no significant difference between balloon angioplasty and orbital atherectomy. So it kind of makes you wonder, but with the caveat being, the patients that were enrolled, they thought they're quote unquote were clinical equipoise. So we did not include patients that had very long diffuse lesions. In fact, the mean length of the lesion was 30 millimeters. So if you have 2 stents that are going to be 38 millimeters long, these are not the patients. Also, if the balloon didn't cross, obviously they're not going to be enrolled in the trial. So what this trial tells us is that very selective use where you can do plain old balloon angioplasty prior to stent with imaging guidance. 67% had imaging guidance, is very important, and it can achieve very comparable results. There is limited data with orbital atherectomy and left main. This is our study, which included 62 patients, very acceptable rates of outcomes at 1 year. Now let's talk about the utilization of IVL and left main disease. So you can see this patient, again, obviously not a surgical candidate, had basically dead myocardium, no viability in distal LAD distribution. So we decided to treat this patient with IVL. Everybody knows about the mechanism. You have acoustic pressure waves that releases energy to cause microfractures of the calcium. So we actually applied a peripheral balloon because we didn't have a coronary IVL. We had a 40 millimeter IVL balloon. And actually, we were able to successfully complete this procedure by putting a stent in the prox LAD. We put a 4018 Zions in the prox LAD. We did simultaneous kissing balloons. And here's the angiographic results. The patient actually did fine. Limited data is available with IVF for left main disease. This is one study with 31 patients. There's only one MACE 30-day MI. So this is our data, and we actually produced a consensus document with Duck Wu and SJ and myself, and we thought that IVL for left main is a very reasonable strategy, but ultimately we need more data. This is one company that I'm working with. This is called electric IVL. One of the main limitations of IVL is that it has a larger crossing profile, so you may not be able to deliver the balloon. This balloon is more tightly wrapped, better delivery, and has an enhanced emitter design. If you look here, it's almost like landing on a runway at Incheon. See how the pulses emit not all at once, but selectively. So they act independent of each other. It has more circumferential electrode firing, resulting in less degradation. So more pulses, faster, and more energy. So in conclusion, the treatment of calcified left main disease is complex. Plaque modification is required to achieve optimal outcomes for severe calcium. IVL may be a reasonable strategy, but ultimately we need more data. Thank you for your attention.
Okay, time is up, but if you have make a comment, just single short comment would be permitted. No? Okay, thank you very much for your attention. I'm closing this session.